So today we're going to be talking about Chapter 9, the dissociative disorders. A bit of a history. The book began with 19th century hysteria. We learned it more common in women, but the book described it as common in the leisure classes, where they basically had nothing to do. The book was a little bit more nice about saying that, where affection and theatricality was more common and fostered repression as a safeguard or a defense mechanism. Basically, it fell out of favor when people entered work and had more concrete things to do each day with a work-driven cultural focus. Around the same time, Pierre Genet introduced the term dissociation, and this should be taken in the context of hysteria and not what we know today to be dissociation. He defined it as belief in complexes outside of awareness that cause hysteria or splits in consciousness as a result of neuropsychological weakness. What we would do more of a holistic wellness approach. He was the key term of the medical model and basically blamed the individual for it, but at the time, that is all that was known, so we might give him a pass for that one. Prince in 1906 described different consciousness in a person without awareness, not focusing attention on a certain consciousness or co-consciousness. Freud described unconscious thoughts meant to ward off painful effects, and instead of dissociation, he termed it repression. And each three of these individuals are important, and when we were deciding how to create diagnostic criteria for the DSM. So keeping those in mind when we go over the diagnostic criteria and where we came from all the way from the 19th century to today is important. Terms to know: dissociation is the splitting off of thoughts, feelings, and behaviors. From a cognitive behavioral standpoint, which most of us are leaning towards, it's easy to see how thoughts, feelings, and behaviors are linked together and can create a lot of symptoms for people that really decrease functioning. But with this association, it's hyped up to another level. The book described it as similar to hypnosis, which is the concentrated alteration in focus with a reduction in stimuli awareness, which is really interesting, and I'll go into it a little bit more later about hypnosis because I didn't really see it as an empirical, validated theory to work from. But we'll work with it. Dissociative states are pathological forms where complex behaviors are outside awareness, such as trances, blackouts, vague amnesia. And sodium amytal, keep this in mind for when we go into some of the treatments, but I thought it'd be interesting when we were talking about some of the historical things, and I didn't know what it was, so it was a good term to know. Injection used for sedation and short-term treatment of insomnia. Basically, it's a talk drug. It makes people very talkative. However, it may cause dizziness, fever, nightmares, anxiety, loss of coordination, hallucinations, and abnormal thinking. When I described some of the symptoms of the different dissociative disorders, you can see how this could be increasingly terrifying when your doctor is giving you this. In amytal interview, they use sodium amytal to promote talkativeness. Most of the times they used it with caffeine because people were just so sleepy. One of the downfalls is that it doesn't ensure truthfulness, and as we know, hysteria, Freud got in a little bit of trouble for introducing different false truths in his patients when he kind of tried to go into the repressive thoughts, but they might not have actually been accurate. It was used in World War II for shell shock, now known as PTSD. However, it made people very ineffective in the field, so it was quickly discontinued. From an Adlerian conceptualization, even though I am from a cognitive behavioral and solution focus, I can appreciate the Adlerian conceptualization mainly because of his emphasis on the safeguarding and some of the precipitating events that go into these diagnoses. So safeguardings can go through symptoms, excuses, aggression, and distance seeking, and that's where you're kind of see some of these disorders. Symptoms was one of the main ones that safeguarding is expressed through. It's the rationalization why an individual hasn't achieved a desired outcome. It's almost this helplessness. It's private logic that excuses a person from taking big risks and moving forward with tasks that would reveal perceived inferior self-view. It's that but I'm sick mentality. So when somebody will be like, why didn't you graduate that class? Well, but I'm sick. And distance seeking. The reduction of feelings of inferiority or pain by distancing oneself from life tasks that can expose these feelings. These especially come out in when people distance themselves from social interactions, which is a big part of Adlerian conceptualization, is how an individual gets their social interaction. And so largely dissociative events, they're precipitating events, the traumatic and their extreme life stressors that trigger maladaptive coping patterns. Perpetrating factors as a flip side are variables that maintain or exacerbate symptoms and problems. People can look at lifestyle convictions, family, themes of early recollection, and social interactions. So we'll kind of take a look at different precipitating events that the book noted for each of them, but they kind of blend together and they're not very happy, just as a warning. So Adler talked about a shock effect, never moving past a particular point. In doing so, the individual believes that they can prevent the event from reoccurring if they just keep dwelling on it. They basically remain at a standstill, don't really accomplish anything. They become discouraged, disengaged from social interests, and experience inferiority complexes that interfere with their life functioning. And that's where we come in to increase that life functioning and get them to move back and accomplish the things that they wish they could do, but they're just stuck in dealing with that trauma. So dissociative identity disorder, these are usually the ones like Split, different movies out there where people have multiple personalities. Split has been not a good representation of what dissociative identity disorder is, but that's the one that I can think of off of my mind. It's a good movie, it's really fun, but not well. So predisposing factors are repeated child abuse, neglect, childhood medical procedures, war, childhood prostitution, sexual assault, and terrorism. What makes this disorder very hard to diagnose are the waxing and waning of symptoms and alteration of presentation of symptoms. So many people might come in with a variety of disorders like anxiety all the way through sleep disorders, and they could say that they've been seeing psychologists, psychiatrists, therapists, their medical doctor for over 10 years, and then finally somebody puts all the symptoms together in a holistic perspective, and it's dissociative identity disorder. They can have other symptoms such as auditory hallucinations, mood swings, thought disorders, amnesia, and suicidal behavior. It's frequent in self-mutilation. They can also be present. For a DSM diagnosis, there's a disruption of identity. So 2 or more distinct identities or personality states with experiences of altered affect, behavior, memory, consciousness, sensory motor functioning, or overall perception as reported by the individual or observers. This part was added in a little bit later, mostly in the early DSM. It was talked about how clinicians needed to observe it, but now individuals who have a more subjective stance can recall and tell you what they were experiencing. There's an average of 10 alters, which are different personalities with descriptive names. It's usually like the protector, the child, the whore, and it comes out in those manners. Memory impairment of important personal information, recall of daily events, and recall of traumatic events. In hearing or learning about this, it almost seems that when the other personalities come out, you take the back seat and you might not recall what was done when that personality took over. It talked about how There was a case about a serial rapist, and when women were describing what attracted them to him, that he almost took on a toddler behavior, and women are very nurturing and they wanted to take care of him, but they noticed he was very different when he was actually perpetrating the act and sitting in the courtroom. So his alter would have been the child in that stance. There's functional impairment, as with any diagnosis, occupational, social, or psychosocial, not caused by direct physiological effects of medication, drug use, or medical conditions. And it's not a part of any cultural or religious practices. So some people can get into that trance, especially sometimes Native American like sweat lodges. So taking that into consideration of cultural and religious practices as well. Differential diagnosis, you need to look out for substance-related disorders, personality disorders, conversion disorders, seizure disorders, or factitious disorders. So from an Adlerian conceptualization, individuals with this disorder are safeguarding against inferiority and to avoid pain. For individuals, especially children who have been abused or sexually abused, they learn to escape their body during that trauma. They might picture themselves floating above their body, not really inside of their body while that trauma is happening. And that's just a coping mechanism they kept throughout their entire lifetime. Whenever they felt unsafe, they just disconnected from that reality. Treatment considerations, it's usually long, demanding, and painful. That can be a consideration when individuals did not get their diagnosis right away. So they've been through the ringer and didn't really know what's wrong with them. If anything is wrong with them from a wholeness perspective and not placing the blame from a medical perspective. The therapist establishes trust. That's important. It's the key to achieving the goal of optimizing patient function and integrating alter personalities. It's not to get rid of all the personalities, it's to integrate them into the main individual's personalities. So like integrating the protector, the child, the whore, all that into your individual personality, who you are. You might not achieve that because that is a lofty goal. So just achieving conflict resolution where the protector might be scornful of the child, so resolving that issue. Different things might be hypnotherapy, psychoanalytical psychotherapy, group therapy, and sodium amytal, that fun drug we talked about earlier. And also managing through other symptoms using medication, so like depression, insomnia, and panic disorders, being able to get those under control while you're doing work targeting the alters. Dissociative amnesia, predisposing factors are trauma, sexual assault, exposure to combat, extreme conflict, and emotional stress. It's a rapid onset and termination of amnesia. However, recovery is gradual and rarely complete. These are the individuals that you usually see. It's rare, but you might have heard of the story about a guy who abandoned his car, abandoned a family back in a certain state, wound up thousands of miles away, years later, started a different name, got a new job, started a new family, and he had no recollection of any of his past events. So a DSM diagnosis is the inability to recall important autobiographical information, and it's usually like a specific topic or memories in the immediate or distant past. Localized or selective amnesia are specific events or partial loss of memory, and generalized amnesia is a complete loss of memory and personal history. That includes identity or knowledge of the world. Those are those people who just up and start a new life. Again, functional impact. Memory loss is too extensive to be explained by ordinary forgetfulness. Like, I constantly forget where I put my keys. That's way less severe than I forgot who I completely am and I'm just going to start a new life, which would suck because I have student debt, and I couldn't really use that to not pay that back. and not doing it to an organic etiology like head injury, alcohol-induced blackout, or seizure-related. With dissociative fag, traveling home from home and work, the inability to remember one's past and may assume an identity. That's what we've been talking about. Differential diagnoses, PTSD, neurocognitive disorders, substance-related disorders, brain injury, seizure disorders, catatonic stupor, fictitious disorder, and malingering, and normal age-related changes in memory. A lot of these are related, so keeping in mind all the disorders that might appear to be dissociative disorders when creating a diagnosis for a client. So the Adlerian conceptualization, safeguarding with distance seeking and symptom arrangement, it's to protect from the pain or inadequacy of being unaware of the event occurring. So you just don't remember that it happened. It's forming that block in it, kind of building that wall between the event and your mind. It preserves the individual's conceptualization of the self. So you might wanting to think that you're a good person, and wanting to maintain that. Self-protection with symptom prevention and withdrawal. Treatment considerations. There's a big goal to recover lost memories, which integrates your trauma and creates that whole identity, and bringing that into consciousness and slowly tearing down that wall. The therapist takes a supportive and empathetic role. They aren't directive. It's more listening skills to elicit that history. You can use hypnosis, free association, suggestion, Amytal interviews, abreactive techniques, and psychotherapy. Depersonalization and derealization. These are two different disorders, however they link them into one diagnostic disorder for the DSM. Depersonalization is alteration in the perception of self, so like a separate observer of the self. So when an individual, like I mentioned, views themselves above their body during trauma, that's kind of a depersonalization experience. Derealization is an alteration in the perception of one's environment, feeling alien, unreal. This can kind of be when people believe that someone has been replaced in their lives, or they just don't feel that they're in the environment anymore, that something has happened. Predisposing factors, again, emotional abuse and neglect, witnessing domestic violence, mentally ill parents, harm avoidant temperament, disconnection and overconnection schematas, poor adaptation, defectiveness, and incomplete themes, trauma and physical abuse. The DSM diagnosis for depersonalization, you experience detachment, unreality, or a sense of being an observer in their body, thoughts, feelings, or actions, emotionally or physically numb, absent from the self, experiencing a distorted sense of time. Derealization is feeling detached from reality, feeling in a dream or lifeless, often accompanies depersonalization, so that's why they put them together. You often experiencing both of these at the same time, which is terrifying. There's a functional impact. There's usually minimal impact because it doesn't last very long. However, you can have more exacerbations and experiences with increased anxiety. And it's not caused by medication, drug abuse, or medical conditions. This is especially important in today's culture where drugs like marijuana can give you these experiences, but not many people are willing to tell you that they have done marijuana. For differential diagnosis, looking out for endless anxiety, MDD, OCD, other dissociative disorders, anxiety, psychotic disorders, substance or medication induced, or mental disorders due to medical conditions, such as like other medical prescribed drugs doing that. Adlerian conceptualization is safeguarding to avoid feelings of inferiority or to protect after trauma. They experience significant decrease in social interest and increase in symptom focus, so they don't, it's that but I'm sick mentality, and pushing away individuals who want you to achieve things in your life that they think that you should be achieving. There's inflexible lifestyle convictions. There's a difficulty bouncing back. I didn't like that term, bouncing back. After a traumatic event, you move away from the trauma and to protect from hurt, pain, discomfort, and you create distance to increase feelings of safety. So it's kind of creating that bubble of safety. So if you don't let anything into that bubble, it's not going to pop. Treatment considerations, your goal is fuller integration of personality and an accurate perception of the self and reality. You can achieve that through hypnosis, imagery, cognitive behavioral therapy, psychoanalytical therapy, group therapy, which is a good consideration for individuals who are pushing away from that social interaction. It can create a feeling of I'm not the only one, and it helps get through the therapy. Sodium amytal, although the book noted that medication is not as effective. So other specified, the clinical presentation, this is largely when people are still, like clinicians are working through and working towards a diagnosis of one of this dissociative or unspecified. For other specified prominent dissociative features, including functional impairment, but they don't really meet criteria. Some examples the book gave, which were very interesting, were brainwashing, duress from hostage situations, indoctrination into cults, and or spirit or demon possession. That's where it lost me, because I, as a counselor in training, we're taught to be very evidence-based, and some of these things like hypnosis and spirit and demon possession don't seem very empirical, but I can see how, obviously, if you're believing that you were possessed, symptoms may come presenting as any of the dissociative disorders. So we'll roll with it. Chronic and recurrent syndromes of missed dissociative symptoms. There's, however, no dissociative amnesia. Identity disturbance due to prolonged and intense coercive persuasion. So you might be questioning your identity, especially indoctrination into cults. You lose your form of identity. Acute dissociative reactions to stressful events. They usually last less than a month. Dissociative trance, and that's an acute loss of awareness of surroundings. So unspecified is more when clinicians are questioning what's the actual diagnosis, and other is more you don't have all the symptoms that meet diagnosis criteria, but you still have something. And here is our reference. This chapter was very interesting in that I did not know a lot about dissociative disorders. It was mainly the dissociative identity disorder that I knew with split personalities, and that depersonalization and derealization, but being able to understand the different diagnostic criteria, how something completely unrelated in the 19th century, such as hysteria, greatly impacted what we consider the diagnostic criteria, and how that can influence us as clinicians. And although I don't believe that I'll ever work with anybody with dissociative disorders, it definitely gave me a more empathetic stance and understanding of people who have a hard time with their mind. That's one of the worst things, I think, and the hardest thing is when you don't believe something in your mind, or you can't recall something even though multiple people have told you that you've done it, and that can be greatly worrisome. So it has given me a different perspective that I can take into whatever I do. So whenever somebody presents with any mental health diagnosis. So that was good. Thank you.